Empathy. What a simple little word with some very complex implications. Empathy is defined as the ability to understand and share the feelings of another, or to feel what that person is experiencing from within their frame of reference. I think of it as the ability to see things through someone else's eyes. I'm proud to be a member of Brown University's MD class of 1975, the inaugural MD class in the modern era. Medical schools then and now begin the lifelong learning process of their students and physicians by helping them to learn all about diseases. And of course, we learned and continue to learn about interviewing a patient, doing a physical examination, and fostering a meaningful doctor-patient relationship. But traditionally, little attention is paid to the third side of this triangle, the relationship of the patient and their families to the disease. Understanding that relationship is the key to empathetic conversations in medicine, seeing the disease, and for that matter, the medical system itself through the eyes of the patient. That's what I'd like to talk about today. 1975, a newly minted medical doctor. My wife and I packed up all of our belongings into a 24-foot U-Haul van and drove halfway across the country to Madison, Wisconsin, where I would be doing my internship and residency. The spring of the following year, I was assigned to be the intern on the hematology service. This was considered to be one of the most intense rotations of the entire training program, and I was grateful it was coming at the end of my internship and not the beginning. We were organized into care teams. Heading the team was the attending physician, Dr. Robert Woodley. He had a reputation for being a tough taskmaster. It would not be until much later that I learned that he was actually a teddy bear in disguise. One resident, 2 interns, and 2 medical students completed the team. Dr. Woodley was a grand master at organizing and running a care team. He made it a collaborative effort, with him establishing the boundaries of care in which we worked. He would make sure that we all understood the medical conditions, the underlying pathophysiology, and the treatment alternatives. As long as we stayed within those boundaries, we had some degree of autonomy. This is an approach I still try and model to this day. One of our patients was Pat Weber, a woman in her mid-40s at the end of a long losing battle against leukemia. It still surprises me that some 45 years later, I still remember nearly everything about her family, her illness, and her care. Pat's leukemia was characterized by having a large excess of cancerous white blood cells circulating through her bloodstream. Moreover, these leukemia cells had taken over her bone marrow, crowding out the normal blood cells. She was running very low on red blood cells that carry oxygen to the tissues, white blood cells that help to fight off infection, and the tiny little particles in the blood called platelets that are the initial line of defense against bleeding. I remember meeting as a team at the end of the day where I was to be the one on call for the night. We all agreed that Pat did not have much longer to live. We had exhausted all treatment options, and we were trying to support her and make her comfortable as best we could. Part of this involved giving transfusions of platelets. This was expensive, and frankly, in the setting of someone who is actively bleeding, they are consumed rapidly and shortly become of little use. We decided as a team there was no point in giving further platelets, given that she did not have much longer to live. That evening, her husband was trying to comfort her. We all knew that the end was only a few hours away. Pat was bleeding from every orifice of her body. Her husband was getting covered with her blood. We had to get him a surgical scrub suit to change into. I looked at the nurse who was caring for Pat and said, "Let's get her some platelets." The nurse looked up, about to object, but then she saw the look in my eyes and saw that I recognized that I was going against the plan the team had outlined and that I had a good reason for doing it. The platelets were ordered up from the blood bank and duly administered to Pat. We were able to clean her up, and her husband could lay propped up in the bed next to her, holding her in her final hours and giving her comfort. She died peacefully in his arms. The next morning, we all met, as was the tradition, for morning rounds. Dr. Woodley asked for an update on what had happened with Pat. The other members of the team were flinching and grimacing, preparing for what they thought would be the inevitable onslaught from our fearless leader, given that I had gone against the wishes of the entire team. I calmly explained the situation of the night before, that I felt her husband was owed the right to comfort her in her final hours without her bleeding out all over him, and that the platelets had succeeded in letting this happen. I sincerely doubt that everybody in the room was actually holding their breath, but I imagined that's what they were doing. Dr. Woodley looked me in the eye and quietly said, "Thank you." I realized later that Dr. Woodley had given me, the opportunity to learn some lessons on my own. This was not the first time that he had seen the situation, and he knew the various ways to handle it. He had given me the opportunity to stretch my wings a little, respecting the guidelines and boundaries that he had provided and making an indelible and lasting impression. We all learned that sometimes our care needs to expand from the treatment of the patient to treating the whole family. Sometime during that pivotal evening, my perspective had shifted as I saw the situation through the eyes of Pat's husband. I had seen his view of his wife's bleeding and how that had the potential to be a memory that he would carry with him the rest of his life. Instead, I gave him a much different memory. That movement, that motion that shifted my perspective from me to the family was at that time unexpected, but essential. Now I know to look for it and to make it happen. Empathy. Many years later, I was back at Brown University and working at the Miriam Hospital in Providence. It was my turn to be the attending physician and to lead my own team. One morning, I arrived to find a very sad situation involving a patient who had been admitted to the intensive care unit overnight. After carefully examining the patient myself and reviewing every nook and cranny of her chart, I called the team together. Interns, residents, students, pharmacists, and nurses, all crowded into a small conference room. I looked around the room and said, I am about to go into that patient's room and tell her husband a bold-faced lie. I want you all to know what that lie is, and I want you all to tell the same lie. The medical students were particularly upset at this, as they had learned in their doctoring course in medical school that one should never lie to a patient or family. The interns and residents simply looked puzzled. The nurses, having more experience, had encountered this particular situation before and suspected correctly what I was up to. The full story was that the patient and her husband had been out for a scenic ride in the car. She was driving but began to feel dizzy and pulled off to the side of the road. She slumped over the wheel and could not be revived. Panicked, her husband took out his cell phone and called 911, and an ambulance was dispatched. Sometime later, it's difficult to estimate time in a situation like this. Sometime later, the EMTs arrived. They found that her heart had stopped in a condition called ventricular fibrillation. And just like on TV, although slightly less dramatic in person, they put metal paddles on either side of her chest, called out, "Clear," and gave an electrical jolt to restart her heart. It did restart, but by this point, the brain had been deprived of blood for too long. Her brain could not be restarted the same way that her heart was. The husband was not only overcome by grief, but he was racked by guilt. He had watched her slump over the wheel and learned later that he had witnessed the exact moment that she had died. He was unable to revive her, and all he knew to do was to call 911. He must have been wondering if he should have started CPR. I walked into that patient's room as her husband joined us at the bedside. This time I fostered that motion and intentionally made the shift in perspective so that I could examine the situation through his eyes. I then looked him squarely in the eye and said, "It wouldn't have made a difference if you had started CPR." The fact is, it probably would have made a difference, as bystander-initiated CPR has been shown to save lives. But what would be the point of telling him that? Rather than launching him on a lifelong guilt trip, I elected a different path. I chose to give him a different memory. What I remember most about this episode is the expression on the faces of the medical students. Initially, they had been resolute in their anger at me for planning to tell a lie and puzzled by the fact that everybody else was going along with it. But then they had an enlightened moment when they realized what I was up to. It was all so simple during lectures, but they were finding that the care of the critically ill and their families is not often so black and white. In the words of Oscar Wilde, the truth is rarely pure and never simple. As I look back over my medical career, I find so many examples of patient care, as well as conversations with the patient and their family, to have been improved through empathy. But an important common denominator is that the conversations were all genuine and heartfelt. If it comes from the heart, it goes to the heart. It took me a while to figure that out. For the longest time, I considered my white coat to be transformative, covering up and disguising the person that I am and turning me into something decidedly more traditionally medical. Until one day, I was on the intensive care unit, caring for an elderly woman who was at the end of her life. Her organ systems were shutting down one by one. It was like standing outside of a building at night, watching the lights being turned off one at a time. I was at her bedside with her daughter, Janet, me in my white coat and Janet with tears streaming down her face. I was terribly saddened by the unfolding events. Her mother's death would be peaceful and dignified, but it was death nonetheless. I knew I was going to start crying too. But people in white coats don't cry. So I turned to walk out of the room so Janet wouldn't see me crying. To this day, I don't know why, but I stopped in the doorway instead, turned, and went back to the bedside. I decided it was okay to cry, okay to be seen crying. Perhaps people in white coats should cry. A few weeks after her mother died, Janet sent me a note, which I have kept to this day. Dear Dr. Elion, it has taken me this long to write to you because I have been searching for the words to express my profound gratitude for your kindness as my mother was dying. Your intuition is remarkable. You knew what I needed to hear even before I asked the questions. I don't think anyone could have guided me as gently, as thoughtfully, or as wisely as you did through the waiting, the decisions, and the end of my mother's life. I'm convinced that this unfolded as it did because I didn't let the white coat transform who I am, but rather I let it augment and enhance who I am. And instead of thinking about the situation just from my own point of view, I used that motion again and made the jump that let me see the entire scene through Janet's eyes. And that made all the difference. While these few short stories that I've shared today come from a medical background, these lessons are certainly not restricted to that environment. In our daily lives, we are confronted with people or situations that may be puzzling. You may find that you're having trouble understanding where the other person is coming from. When that happens, use that motion. You're likely to find things will be far more understandable when viewed through the eyes of the other person. You don't actually had to have experienced the situation before to be empathetic. Just view the situation through their eyes. This has helped me immeasurably over many years in taking care of my patients and in having meaningful conversations with them and with their families. We all have times when we don the mantle, assuming a persona and a role when we interact with other people. Many times, that persona has a visible representation, the white coat of medical students and physicians, the uniform of a policeman or soldier, the three-piece suit of a Wall Street tycoon, the attire, formal or informal, of a waitress, a teacher, a fireman, a banker, a bank teller, a shopkeeper. Don't let it get in the way of your ability to use that motion to see things from the other person's perspective. You'll find that the view is a lot better and a lot richer when you bring all of you to the conversation. That's empathy.